Yeah. Gary, going on that path a little further, are we talking about those athletes that are not complaining of anything, but are you suggesting that there's a possibility that we could screen their spines, find some stiffness, some loss of motion there, identify that, yes, in fact, they show one of these poor landing or takeoff or forward locomotion type of behaviors that these two guys have talked about, and just clear that limited motion at the lumbar spine, and perhaps you would see those patterns go away?
Possibly. And again, I don't have that data, but I'm just saying, hey, what if? Because, as long as the hip is weak, right? I don't think anything else down the chain functions properly anyway. I think everybody would agree with that. Mm-hmm. So if you as a clinician go in and say, okay, this guy or girl's hip abductors are weak, well, the next question I would ask you is, why are they weak? Mm-hmm. Is it a true weakness? Because it'll take you 2 months to make them stronger, mm-hmm. right? Or is it inhibited from another source? And I'll even go as far as to say, is it, in our terms, it would be lumbar derangement, because you would see the rapid change in that baseline if you found a key movement for that. Mm-hmm. And then if you had a hip derangement, so you had something at the hip itself, that joint, you'd screen the spine, screen the hip, and find that key movement that would call, that would reinstate that power, within the session or between sessions. Mm-hmm. So if you can do that, you can control that, recognize it. Does it change the pattern? Mm-hmm. And I don't know the answer to that, but I'm just saying, if you guys are looking at these patterns, and part of those is, hey, you're not powerful enough here, you're too powerful enough there, you're weak here, then I think some of that comes back in. It's like, okay, well, how are you assessing the weakness?
Sure. Yeah. Right. And I think that I heard Gary Scheffler with this GOTA approach say, look, we're looking at the foot primarily, and things that might happen up the chain, well, that's all fine and good, but we're going to focus on retraining these athletes so that their foot pattern looks like we think they ought to look, or like we've seen these people who've been in leagues for many decades and they've not had any complaints of any lower extremity non-contact complaints. So could we also, in that respect, could we look at, okay, let's take a look at plantar flexor strength, dorsiflexor strength, eversion strength at the foot and ankle, and then find some concordant limitation and perhaps work on that limitation somewhere through the lower extremity of the lumbar spine?
I 100% agree with that. Yeah. Or yes, I agree that that's a true statement. I think and again, I shouldn't say yes, but I think again, and let me go back a little bit in time. And this, unbeknownst to me at the time, when I worked, and part of my history is I worked in pain management for a little over 5 years. And so with that environment, I was trying to find baselines that I could lean on to trust, because some of the subjective data, some of the subjective baselines is, take VAS scale and things like that. And that environment is not necessarily the one you want to trust the most, right?
Yeah. Right.
It's more about, mechanical and functional baselines, and do they change? And so if you can see and appreciate that, then you might have something, right? Yeah. Well, I started screening people. They have back pain. I'd screen the ankle, screen the knee, I'd screen the hip. And I would find weakness, right? Non-radicular complaints, but weakness that was an inhibition in the ankle dorsiflexors, everters. And I would see occasionally loss of motion at the knee. Mm-hmm. And I would see inhibited hip flexion, hip abduction power. And you may or may not see loss of motion at that hip if you look at it from a movement with overpressure passively as well. And then you gather those baselines, distal to proximal. This has been a thing I've kind of been on for a little while now. Distal to proximal gathering of baselines. And then you test proximal to distal. So I would test lumbar spine first. What did it do to the hip? What did it do to the knee? What did it do to the ankle? Mm-hmm. And if you have a lumbar source of problems, which again, if you have that multiple joint presentation where you have ankle, knee, hip, I would bet you that you're going to have some lumbar component there. Mm-hmm. Move the lumbar spine, go back, retest ankle, retest knee, retest hip, right? Mm-hmm. And so if you can see, and again, these are inhibited powers. These baselines are inhibited, right? So they're almost, pseudo losses of power. And if you can turn that back on, then you look back at that, what you think is wrong. Is it different? I don't know. I mean, you may still have to learn the pattern, the right pattern, but if you're not strong enough, if that's part of the thing they're trying to fix, if you can't get stronger because there's inhibition, then you better learn how to turn the inhibition off.
Yeah.
Does that make sense?
I definitely follow you. Yeah. It's interesting to think about the asymptomatic piece there, because I don't think many of us, maybe I'm speaking out of turn here, but I'm not thought about people walking around with no complaints. They're functioning pretty high level. They may be, athletes or whatever, and they don't feel any symptoms, but yet they might have some things that might predispose them to injury down the road, and that we might be able to pick up with some of these passive range tests or strength tests, manual testing. And you're talking about manual testing.
Yes. And again, the people that I work with, I try to work with them on how that might look. I mean, and again, that matters because the expectation of how a brake test should look and how you address that versus, hey, listen, let me test your wrist extension here. And okay, that's good. That's not getting it. I mean, that muscle shouldn't break and I need to know it's fully functional. Yeah. I'm looking for a baseline. So and I'll retest that. So they know what hey, listen, I'm coming back and I'm going to give it to you a little harder this time. Give it everything you got. And people will load up and they'll try to stop it and they just can't stop it.
Yeah. And
so it's like, okay, that's a baseline. I'll usually write that on my dry erase board, which that story. Write that on my dry erase board so they can visualize that baseline. Mm-hmm. And it's so like I say, if you're symptomatic lumbar, symptomatic cervical, even I would screen the upper extremity for baselines, even in a non-radicular complaint. And don't be surprised if you really go looking for those, what you find.
Mm-hmm. Yeah, excellent. Good food for thought. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.